So I'm so excited that we're all here today to be able to listen to Dr. Skye Fitzpatrick regarding PTSD. In 2015, this is when we started to connect. And while Dr. Skye Fitzpatrick was a PhD student at Ryerson, she reached out to Sashbear to put one of her research studies on BPD. And since then, we had many occasions to collaborate, and it's always an honor for us to support her important work in any way we can. Dr. Fitzpatrick completed a PhD in 2018 at Ryerson University in the Borderline Personality Disorder and Emotion Processing Laboratory under Dr. Janice Guo supervision. Her research at Ryerson focused on the nature and treatment of borderline personality disorder with a specific focus on dialectical behavioral therapy, DBT. Dr. Fitzpatrick's training at Ryerson supported her in achieving numerous awards, including the Governor General's Academic Gold Medal Award, wow, and the American Psychological Association Dissertation Research Award, incredible, and the Dennis Mock Student Leadership Award, amongst others. Following graduate school, Dr. Fitzpatrick completed a pre-doctoral internship in Seattle at the University of Washington under the research mentorship of Dr. Deborah Kaysen. During her internship, she received research and clinical training in the treatment of post-traumatic stress disorder, PTSD, which often co-occurs with BPD, and was awarded the Nancy Robinson Award for Outstanding Overall Achievement for her contribution to the training program. Dr. Fitzpatrick continued to pursue training in both BPD and PTSD treatment research during her postdoctoral fellowship in the Center of Alcohol Studies at Rutgers University under the mentorship of Dr. Denise Yin and Dr. Sharon Ridsby. Her current research interests focus on the examination of emotion processes in the treatment of BPD and PTSD. And identify ways to streamline and refine concurrent treatment for this comorbidity. Without further ado, Dr. Skye Fitzpatrick.
Hi, thank you so much for that introduction. And thank you so much for having me. It is truly such an honor to be here with Sashbear, with all of you, people who have loved ones with BPD, people who have BPD, family connections leaders. I really admire the work Sashbear has done, that Family Connections does broadly. It means a lot to be here. So thank you so much for having me, and thank you so much for coming. I'm going to share my screen because I have some slides. Okay, so hopefully you can see that. If you can't, or if there's any problems hearing me, or maybe Kathleen or Doreen or Lynn can interrupt me and let me know, but I'm gonna get started. Okay, so I am here to talk to you about PTSD and BPD, how they go together, how we can think about treating these two things together. I want to start by just giving you, I don't want to talk about myself for too long, just giving you a brief preview to understand who I am and the context with which I come at these things. And then I want to talk a little bit more about what PTSD actually is, how it intersects with BPD, how to understand PTSD in a sort of evidence-based way, and then how to think about treating it when people have both PTSD and BPD, or some pieces of both of those things. So I am the director of a lab that I call the TULIP lab at York University. That's an acronym that I've kind of forced a little, but it stands for Treating and Understanding Life-Threatening Behavior and Post-Traumatic Stress. And what I'm really interested in, as Lynn said, is I'm really interested in finding ways to treat people who have BPD and people who have PTSD more effectively and more quickly. But I do that with a specific angle. And there's two real factors that I bring into that, and hopefully that'll be apparent through the presentation. One is that I really believe in the power of interpersonal relationships. I really think that relationships are really important to recovery when people have BPD and when they have PTSD, and that loved ones of people with these conditions can also suffer. And so really, I'm very interested in taking a holistic approach and treating these conditions both with the individual who has them and their loved ones at the same time, to see if we can help people recover and enhance relationships and enhance loved one mental health all at the same time. And I'm also really interested in finding ways that are scalable and accessible to treat these things. Can we overcome waitlist barriers, access problems, and get people treatments quickly, online, do whatever we need to do to get people the care that they need so that people aren't sitting on waitlists for too long. Those are kind of the areas that I think about, and that might be apparent as I talk through this. But today I'm really going to talk about these top two quadrants, BPD, PTSD, how they go together, how do we treat them, all that kind of stuff. And before we get into that, I just want to start with a brief story. I think it's really easy, especially for academics, to talk about BPD and PTSD like they're these ideas, these concepts. But for people who are living with both of these things, it's not necessarily so easy to separate them and talk about them so academically. And I just want to start with a story of somebody who I'm calling Roberta. That's not their real name, but somebody that I met in a hospital who came in, had multiple suicide attempts, had a diagnosis of BPD. And this was my first time talking to her. And I had asked her, and we were starting to try and figure out together what was leading to these suicide attempts. And this person had a very long trauma history. And what became apparent through our conversation was that one of the main things that happened before they tried to hurt themselves a lot of the time was that they would have a flashback of a traumatic memory. And really, in that way, it became really clear that BPD and PTSD and these ideas, they're not so separable for her, that really the trauma was like this thing that was festering at the core of so many problems of what she was dealing with. And even though she had been through treatment systems for over a decade, she'd never received an evidence-based treatment for PTSD or for BPD. And yet it seemed so obvious. And to me, I think that really speaks to the work we need to do here, that these two issues for people become really tied together. And until we can really recognize and understand that we need to be able to target both of those things, we're leaving pieces out. So that's part of the impetus of this talk and my research in this area. So I want to give some context for that intersection a little bit more and just look at the statistics. We know that a lot of people with BPD have trauma histories. They experience traumatic events, often in childhood. That's very, very common, but throughout the lifespan as well. It's much more common in BPD than it would be in the general population. And we know that in some studies, over half of people with BPD, up to almost 60% of people with a BPD diagnosis, a borderline personality disorder diagnosis, have PTSD. That's a lot of people. And we also know that when people have both BPD and PTSD, sometimes it can increase the severity of both of those problems. It can sometimes make PTSD more severe. It can make BPD more severe. They can kind of interact with each other, which is part of the reason we really need to think about treating both of them together when we can. They can interact with each other in a way that can be quite difficult for people who are living with that. Now, fortunately, we know we have really good treatments for BPD. DBT would be one of the main ones, dialectical behavior therapy. And DBT has shown a lot of evidence in also reducing other things that come along with BPD, things like depression and anxiety. But sometimes the research shows that when people go through standard DBT as it is, PTSD does not always resolve. So it still tends to linger. So that is something that for a while was a bit left out that we really need to figure out, because a lot of people were getting better in a lot of ways, but still having this PTSD that was really bothersome, really quite distressing. So I'm going to talk about what PTSD is and how do we take a step back from that in a moment. But before I do that, I just want to clarify when I use trauma versus PTSD, what I mean by that and how these are really different things. So trauma is really the experience of something traumatic, a traumatic event. So those are the things that you might typically think as traumatics. assaults, attacks, various things that have this effect of traumatizing people. Post-traumatic stress disorder, PTSD, is quite different from that. PTSD is a set of symptoms that follows trauma, but not everybody who experiences trauma has PTSD. And I'm going to talk more about what's going on with that and why we think that is later. But let's talk first about what PTSD actually is. How do we understand it? So you can understand PTSD as having 4 symptom groups. They're kind of 4 clusters of symptoms: hyperarousal symptoms, avoidance, numbing, and intrusive symptoms. All of these symptoms impact our relationships. And our relationships also impact all of these symptoms. They kind of interact with each other. So let's start with the first group of symptoms, the intrusive symptoms. What does that mean? Intrusive symptoms involve the trauma intruding on your life. Okay, it's like there's these intruders that come into your mind and remind you of trauma. So some of the most classic PTSD symptoms are the intrusive symptoms, things like having nightmares about a traumatic event, flashbacks, where it feels like all of a sudden the traumatic event is happening all over and over and over again. And as well, you might just have memories. It might not be like a flashback, but you're walking down the street and when you least expect it, a memory pops into your mind and reminds you of that traumatic event. Those kinds of symptoms can affect our relationships in all kinds of ways. So if you have a loved one, a partner, if you're in a romantic relationship with somebody who has PTSD, you might find yourself sleeping in separate beds due to nightmares. Loved ones might need to intervene when a flashback is happening to try and remind the person that they're here, that they're safe. And as well, you might notice that loved ones seem distracted. You know, they're preoccupied by memories of trauma that are coming into their mind. Those intrusive symptoms can be so unpleasant that they lead to this fight or flight reaction, which is broadly called the hyperarousal symptoms. So hyperarousal symptoms mean that your mind or body is hyper or overactivated. They're revving too much. So when you're constantly being reminded of these extremely difficult, traumatic, distressing events, your body starts to react as if you were in a trauma right then and there. So you have this fight or flight response kick in. So you might have really intense emotion or body changes when something reminds you of a trauma. When you hear a word or smell a smell or hear a song or see an image that reminds you of it, all of a sudden you're feeling really much more distressed than you were before. People often feel really on guard and vigilant, like they kind of have to be watchful all the time for potential danger. People have problems sleeping or insomnia. They get jumpy, so they have what we call high startle sometimes. Like if somebody claps your hands behind you, you may jump more than somebody else does. And then there's other problems too, like often people develop more anger or problems with anger outbursts. Or people start to just develop more negative emotions than they used to have before a trauma in general, more anxiety, guilt, shame, sadness. And you can see here, if you know sort of the BPD criteria, which involves a lot of emotion and emotion dysregulation, you can see how these things start to swirl together, right? If somebody has PTSD and their emotions are going all over the place, that is also a big part of what can happen in BPD. So these things start to move together in this way that can be really unpleasant. And when you have a lot of hyperarousal symptoms, it can really influence your relationships in a lot of different ways. One way is that if there's a lot of anger, if you have a lot of emotion, there can just be a lot more conflict in your relationships. And in addition to that, you know, sometimes loved ones with PTSD can seem a bit controlling if they feel like they have to control their environment in very specific ways to feel safe, you know, make sure they're sitting in specific areas, that they are driving in specific ways to feel safe. That can happen too. And in general, when you're on guard all the time, when you're in fight or flight so much, it's just hard to feel close to each other. When you are experiencing so many intrusive symptoms, so much hyperarousal, all of that fight or flight, all of that distress, a really natural reaction and response to that is to try and avoid trauma reminders and try and avoid all the things that remind you of the trauma and cause that distress in the first place. And that's really the next set of symptoms. It's the avoidance symptoms. So people with PTSD often try and avoid all kinds of things that remind them of the trauma. It could be people, certain places that remind them of the trauma, certain thoughts that they have. They can avoid thoughts in their own mind. And avoidance doesn't just take the form of, I'm not going down, walking down by that alley. I'm not going, to talk to that person. Avoidance can take the form of doing things to try and numb yourself out, like drinking or drug use, overworking, or even doing kind of reckless things like driving really fast, things that could hurt you, binge eating, shoplifting, all those kinds of things can really be part of a broader experience of avoidance. And one thing I want to say about this that's really important to keep in mind is that it is so natural to want to avoid following trauma because it does get distressed down in the short term. But avoidance plays a really big role in keeping PTSD going. And the reason that it does that is because when you prevent yourself from thinking about trauma, from, looking at images or something that reminds you of trauma, what that basically does is it prevents you from actually processing the trauma and learning that, in this moment right now, you are not in a trauma, that you are safe. And that a memory of a trauma is not as dangerous as a trauma itself. If you always avoid the memory of the trauma, your system doesn't get a chance to learn that. So it keeps revving whenever it gets reminded of the trauma. And I'll say a little bit more about that later. But one thing I wanted to highlight is that family members and loved ones can play a really important role here with the avoidance symptoms, with something that we call accommodation. It's really normal to try and help your loved one with PTSD avoid trauma reminders because you don't want them to be upset. Nobody wants their loved ones to feel upset. So one way that we see a lot of loved ones working with people with PTSD is doing things to kind of help them avoid. Like if somebody got into a car accident, the loved one might drive and not, so that the person with PTSD doesn't have to drive. You might, go to a restaurant and have the loved one sit with their back to the door, and so that the person with PTSD can sit with a wall behind them so they can scan the restaurant for danger. All these kinds of things help the person feel safe in the moment, but they can play a role in keeping PTSD going by accident by kind of engaging in some of these avoidance behaviors. So that's just one thing to know. And then another way that people start to try and avoid and get rid of all the distress from the intrusive and the hyperarousal symptoms is numbing. People start to experience these symptoms that have them kind of numb out from emotion so that they kind of can disconnect from all the distress and pain that they're in. The problem with numbing is that it kind of functions like avoidance, and it doesn't just get rid of negative emotions, it gets rid of positive emotions too. So a lot of people with PTSD start to have difficulty feeling any emotion at all. They don't feel as interested in things. They might seem more depressed in that way. And they start to feel disconnected sometimes from the people around them. And this has a really obvious impact in our relationships, right? Because feelings are how we connect. Emotion is the glue that holds our relationships together, all kinds of relationships. So often when people have a lot of numbing symptoms, it's harder to feel close for both them and for their loved ones. So you might notice that too. I should say you don't need all of these symptoms, everything I mentioned, to have PTSD. But typically people have experiences from each of these groups, and you can see that they all influence each other, right? The intrusive symptoms kind of fire up the hyperarousal symptoms because the reminders of the trauma are so distressing. And then people start to respond to those hyperarousal and intrusive symptoms by avoiding and numbing out. And avoiding and numbing out kind of feeds the intrusive symptoms by preventing the processing of that trauma. All in this vicious cycle. And relationships are kind of impacted by all of these symptoms, and kind of can radiate out and impact the symptoms too. So here's the other really important thing to understand about PTSD. Trauma affects almost everybody. Okay, so if you actually poll the population, the percentage of people who will experience something that the Diagnostic and Statistical Manual of Mental Disorders, the DSM, would call a traumatic event, which is quite severe, is like 80 to 90% of the population. Most of us are going to experience trauma in our lifetime. But 10%, up to 10%, sometimes less, will have a diagnosis of PTSD in their lifetime. So something is different there, right? Most of us experience trauma, but not all of us get PTSD. So how do we make sense of that? Who's getting PTSD versus who's not getting PTSD? What we know is that PTSD symptoms are actually kind of the normal or common response immediately following trauma. So I have a little fake graph here. The passage of time is the x-axis, and PTSD severity is sort of that y-axis. And all this means is that most people immediately following a trauma will have PTSD symptoms. They will have a lot of the symptoms that I just talked about. But if you follow them for the weeks or months following a trauma, they tend to kind of resolve on their own. When people have PTSD, it's like this yellow line. They have the symptoms too, but they don't go away on their own. So what we know is happening is something is preventing the recovery that other people are having. And for that reason, we think of PTSD as a disorder of stalled recovery. Something's getting you stuck, getting in the way of your natural recovery. And so the goal is to find out what is getting you stuck and remove it so that natural recovery process can happen. That's PTSD in a nutshell. But that's PTSD as a standalone disorder. I really want to talk now about PTSD and BPD together and how we can start to think about the treatment of those two things. Okay, so what do we know about treating BPD and PTSD? All right, so we know we have good treatments for BPD. Dialectical behavior therapy is, of course, the main one that I practice and study, but there are many more. There are other treatments as well. The problem, as I said before, is that sometimes PTSD severity does decrease as a result of a straight BPD treatment like DBT, but sometimes it doesn't. Sometimes there can be some remaining PTSD following that. What we don't know as much about is what happens if I try and treat your PTSD. If I treat the PTSD, that will probably go down. We know that there's lots of PTSD treatments that work. But what happens to the BPD? Will the BPD also improve if I treat PTSD? Or do I have to treat them both at the same time and really be focusing on one versus the other? This is really a pressing question in the research literature right now. There's lots of different perspectives on it. And I'm going to present you some of those perspectives and ideas today. So you can think about there being three main approaches to treatment when people have BPD and PTSD. So the yellow chunk is the BPD treatments. That would be like straight dialectical behavior therapy or something else like that, where you're not explicitly talking about trauma and you're not explicitly trying to help somebody with PTSD get better. Those have a lot of great empirical support for the treatment of BPD. There are also PTSD or trauma-focused treatments that are not talking about BPD. They're not talking about suicide. They're not talking about self-harm. They're really trying to treat your PTSD, and that is it. And then there are this gray chunk, these treatments that try and integrate and combine these different elements of the two to try and help people who have this kind of mixture of problems recover from both of them simultaneously. I'm not going to talk about the BPD treatments today. That is dialectical behavior therapy as I think the gold standard approach. And I think that's probably more well known to a lot of people on this thread. I'm really going to focus on the other two slices of this pie. There are many trauma-focused treatments that have strong empirical support. That's, I think, a really important and encouraging piece of good news is that the treatments for PTSD have quite strong research behind them as being effective for treating this problem. There are many out there. I'm going to highlight a few really common ones that have received some of the most empirical support. Prolonged exposure would be one. Cognitive processing therapy is another. Cognitive behavioral conjoint therapy has not been studied as much as those two therapies, but I did want to note it. I'm not going to talk about it too much, but I did want to note it because that is a treatment that was developed by Candice Monson, who is here in Toronto and is a collaborator of mine. But it's a treatment that treats PTSD in conjoint form. And what that means is that loved ones and the person with PTSD attend treatment. And the research suggests that it both is effective in treating PTSD, but also enhances relationship functioning and improves loved one mental health as well. So that's just something to know about as another treatment option. I'm going to talk about prolonged exposure though first. So Prolonged exposure is a behavioral treatment. And what that means is that it focuses a lot on what you're doing, and it actually goes really well with DBT because DBT itself is also very behavioral. The central idea in prolonged exposure is that people develop fear structures from trauma. What that basically means is that if I am swimming and I encounter a shark, all of a sudden this network of ideas is going to form in my brain. The image of a shark will become associated with the reaction I'm going to have, this fight or flight reaction. My heart's going to race. I'm going to have the urge to swim away and escape. And I might have some thoughts too, like this is dangerous. This is a problem. You know, that's called a shark fear structure, like this mental network in my brain. And the idea is that that is actually an adaptive thing, because next time I see a shark, if that whole fear structure activates, it's going to get me to run away, or swim away rather, really quickly and protect myself. But the problem is that in PTSD, people's fear structures start to become a little too broad. So think about now not having that reaction, not in response to an actual shark, but in response to a picture of a shark or a memory of a shark. You are no longer in the danger that you were in when you were in the ocean, but your body now is reacting as if it was. That's sort of part of the prolonged exposure theory about what is going on in PTSD. And prolonged exposure therapists would say that when people avoid things that remind them of trauma, when they avoid reminders or thinking about trauma or going to places that remind them of the trauma or the memory itself, they prevent that fear structure from being updated. They prevent their system from learning that, oh, if I just have this memory, it's very painful, but it's not dangerous the way a trauma was dangerous. Or looking at this picture is stressful, but it's not dangerous to me the way actually being confronted with this trauma was dangerous. The only way to learn that, to have that correction, is to actually engage with some of the things that you're avoiding. And so the treatment involves activating the fear structure and kind of trying to update this information in it. And what that basically means is purposely trying to remember the trauma in a safe environment and purposely doing things that PTSD would normally have you avoid that are safe. You know, obviously not putting yourself in an actual dangerous situation, but doing things that you've been avoiding because they make you afraid or something like that. So that these fear structures have an opportunity to kind of correct themselves and update through your own experience. Cognitive processing therapy is a different treatment that takes a totally different approach to PTSD. Although I think cognitive processing therapy would agree with a lot of that idea about avoidance in PTSD, it's much more focused on the way people make meaning out of trauma. And how they understand what has happened to them and what that means about themselves, about the world, about other people. And so one example of something that's often talked about in cognitive processing therapy is the idea of a just world belief. This is this basic idea that good things happen to good people and bad things happen to bad people. And a lot of us are taught this belief as kids. You know, this is kind of how what you learn when somebody says to you, like, if you do that thing, you're going to get in trouble, you know, subtly teaching you that, okay, if I do a bad thing, bad things are going to happen to me. So a lot of us have these kinds of beliefs. The problem is those beliefs don't square so well with trauma, right? If you on some level think good things happen to good people, bad things happen to bad people, and then a bad thing happens to you, how do you make sense of that? Now you have these two beliefs that don't go so well together. And so the idea in cognitive processing therapy is that part of how people try and reconcile those beliefs, how they try and make sense of a trauma, can sometimes keep them stuck. Like if I try and reconcile those beliefs by saying, oh, I must be a bad person, that's why this happened to me, that kind of meaning is maybe not so accurate or helpful, and it's going to kind of keep me stuck and prevent that natural trauma PTSD recovery that I was talking about earlier. So this treatment really involves finding these stuck points in your thinking that keep you stuck or are unhelpful around how you've processed and understood the trauma, and helping people to change their meaning, helping people to understand what has happened to them in a new way and come up with a story around it that's kind of more helpful for them and effective and balanced. I just want to say one more thing, just as a plug, if there's any podcast listeners out there, a very, very popular podcast called This American Life. It's like, I feel like it's like the podcast. It's very, very famous, but there's an episode on there called 10 Sessions, wherein somebody who had PTSD sought out a cognitive processing therapy expert who is a mentor of mine, and recorded her experience and of going through that and receiving the treatment. And I think that's a really great listen for those of you who want to kind of hear what that treatment is like, or interested in it and want to know more about it and want to hear about it from kind of a lived experience. That could be one way to get in contact with that. The real takeaways, the take homes that I want to leave you with for trauma-focused treatments that are the most empirically supported or most well studied is that they involve trauma processing in some way. They normally involve talking about trauma, trying to engage with trauma, and trying to get people to stop avoiding as much as they can, and as understandable as avoidance is. Many people feel that people need to be ready for trauma processing treatments because they're, you know, sometimes distressing. They can be hard to talk about some of the most painful moments of your life. And so often people suggest that when people have a high risk of suicide, when they are suicidal, they engage in suicidal behavior a lot, that they're not ready for PTSD treatments. And I think that's really an empirical question that we don't have the answer to yet. We don't really know when is the right time to do a PTSD treatment. There is some research that treating PTSD is effective, can be effectively done in people who have BPD, but those studies are often preliminary. Sometimes because people with BPD who have some problems like feeling suicidal or being really suicidal often results in them getting excluded from some of these PTSD treatment studies. So we don't really know yet, and I think this is a really important piece of the puzzle that we're starting to figure out now. Now, over to the combined treatment. So what do we do when we try and combine PTSD and BPD treatment? I'm going to talk about those a little bit today too. So one option for that is called DBT-PE. It's DBT plus prolonged exposure. Actually, the full name is DBT plus DBT-PE, and it was developed by Melanie Harnett at the University of Washington. And in a nutshell, this treatment involves adding a slightly modified 90-minute prolonged exposure session to standard DBT. So you're going through normal DBT, you have skills groups, you do individual therapy, all the components of a straight DBT treatment, and then you add on, when clients are ready, you add on these prolonged exposure sessions to treat the PTSD. There are rules, for now, conventions, I should say more than rules, around when people have begun to do this PTSD part of the treatment. Usually it's when there's no imminent risk of suicide, when they haven't self-harmed or attempted suicide in the past 2 months. So those kinds of more life-threatening behaviors are under control, that they can control those urges, that they want to do work on their PTSD, and that they're willing to experience some painful trauma-related emotions. So even here you can see this idea that there has been quite a lot of thought put into when are people ready for a PTSD treatment, and if they're not ready right now, what can we do to help get them ready so that they can do that treatment? That's one very common approach. And what I do want to say about this treatment in particular is that the preliminary results are really strong, that it has double the rates of remission, which means recovery for people with PTSD than standard DBT alone, that it reduces the likelihood of attempting suicide by 2.4 times. So that's quite significant. And it reduces the likelihood of self-harm. So this is a really interesting and important finding because it suggests that when we can treat PTSD, some of those life-threatening issues and BPD and suicidal behavior and self-harm, you know, those things might actually get better too. So we really need to figure out how to get people these treatments. The other treatment that's very common, that's a combined treatment, is DBT-PTSD, which was developed by researchers in Germany, led by Martin Bohus, which combines DBT also with prolonged exposure and then some more cognitive therapy elements. For those of you who are familiar with the concept of radical acceptance, my understanding is that radical acceptance is a really important part of this treatment. Of radical acceptance of trauma, that there's more work on specific trauma-related emotions like shame and guilt, and that from the studies that I've read of DBT-PTSD, people can start to do this treatment when they haven't engaged in any suicidal behavior in the past 2 to 4 months. So again, you can see this kind of sequencing idea, which is present in that. And there's good research suggesting that it has outperformed some other treatments, treatment as usual, which is sort of like the standard treatment people get in reducing PTSD symptoms. So those are really promising things. The take home about combined treatments is that they're new, they're not as old as DBT. They haven't been around since, the early 90s, late 80s. But it's really promising that we are figuring out how to do this, and we are figuring out when to do it. And that treating PTSD actually might be super important for people who have it, because it might help both their PTSD and their BPD. So too early to know exactly for sure, but there's a lot of, there is preliminary research to suggest that that's the case. But we have to figure out how to get people into PTSD treatments. When are people ready for PTSD? Do we need to wait till, all that stabilization has happened, or can we give it to people right away? We don't know the answers to those questions. We don't know when the right time to do it is fully yet. It hasn't been explicitly studied. And so this is an important future direction that both myself and many of my colleagues and many people in the field are studying, to try and figure out, how do we get these people treatments that we think that they need? Okay, so where are we going down the road? What I'm interested in, I can't say what every researcher is doing. What I get interested in is trying to figure out, how do we treat BPD? How do we treat people who have BPD and PTSD better and faster? How do we get people the care they need and get it to them quickly, so that we can get it to more people and more people and more people? That for me involves figuring out, like some of the questions I mentioned earlier. How do we treat PTSD? Can we do it in a streamlined way? Can we do it in a simple way that will affect and improve BPD? That's a question mark. And I'm very interested in seeing if we can optimize BPD treatment by harnessing the power of relationships, developing treatments for people with BPD and their loved ones to go through together, to try and enhance relationships, enhance loved one mental health, enhance BPD, or improve BPD at the same time. Those are some of the questions that I'm interested in. But before I finish, maybe I'll just leave you with one thing, is that I know that's a lot of questions, and maybe this raises more questions than it answers. What I want to tell you is that in the last decade, the number of people who've been studying these questions and these issues has grown dramatically, that there's tons of work being done on this, and there is really a growing body of literature that suggests that we can do this. We can treat people who have BPD and PTSD effectively. We can figure out how to do that. And now we're just trying to figure out how to do it quickly and how to get it to people. So there's a lot of hope. There's a lot of hope, and there's a lot of big progress that I think is really on the horizon and in our future. Okay, that was a lot of information. Thank you so much for listening. I'm ready to take questions. I do have my lab website there. So for those who are in the area who are interested in ever seeing what we're doing, looking up to see if we have any studies open, all that kind of stuff, you can always check in there. But maybe now I'll turn it over to some questions.
Okay, great. Thank you so much, Skye. One question that's come up repeatedly is around the efficacy of EMDR, which is the thing that most of us hear about as a treatment for trauma.
Yes, yeah, that's a great question. So EMDR is been extensively researched as a PTSD treatment, and does have evidence as being effective in treating PTSD. There is some debate in the literature about why it is effective, because EMDR, for those of you who don't know, involves some trauma processing, some of what I've talked about, and also has some work done around eye movements and moving eyes in specific ways. There is some debate in the literature about whether the eye movements are the active ingredient of the treatment, or whether it's really kind of the exposure and trauma processing that you see in some of the other treatments that I've talked about. So that is often discussed, but EMDR does have a strong basis of empirical support behind it. to my knowledge, it's not been extensively studied in BPD, but neither have the other trauma-focused treatments that I've mentioned.
Thank you. I've had a couple of questions come through about youth, teens in particular. One around whether any of these combined therapies have actually been researched in dealing with the teenage and youth population, young adult population. And another one just around how generally do you encourage teenagers to be ready for treatment around PTSD, or encourage them to participate in it?
Those are great questions. So full disclosure, I don't really treat youth. So I think that's the one thing that I want to say. I'm not familiar with research that has done like a full clinical trial of DBT-PE or DBT-PTSD in adolescents or in youth, although it's possible that some of that work is on the horizon. I am familiar with some like individual cases I know that people have done similar treatments with. There are certainly many evidence-based PTSD treatments for youth. Trauma-focused CBT is one that, cognitive behavioral therapy is one that comes to mind. In terms of how to encourage youth, I think that's a really good question too. I mean, one way that again, not being a clinician who works with youth, I think one thing that comes to mind is helping them understand the impact that PTSD is having, that it's not fun to have PTSD, and most people don't want PTSD, and understand that there's actually a life that they can live where they don't have these flashbacks, these nightmares, these really distressing symptoms that are causing them a lot of pain, that they can actually do things that kind of free them up from a lot of that. And so part of my inclination is really around psychoeducation. And then the other piece that I think about is that a lot of DBT providers want to have their clients get PTSD treatment. And a goal of DBT treatment to work on with a DBT therapist could be getting ready for PTSD treatment, doing what you need to do to get ready to be able to do it. So that would be the other thing I would be thinking about too.
So, and also there are a lot of questions coming out about how do we help support somebody, how do we encourage them to get treatment? And that seems to be a real theme that's running through what you're saying, that the DBT treatment is that precursor for a lot of people if they have overlapping symptoms of BPD and PTSD.
For now, that is the most researched option. How to help and support somebody with PTSD, I think, is a really vital question. There's a lot of research that shows that social support is one of the biggest predictors of how severe PTSD, whether PTSD happens after trauma and how severe it gets. So the reactions that we have to people who are living through trauma when they tell us about their traumas are actually really important. There's obviously really obvious things to think about, like don't victim blame, don't say something that, would obviously be harmful, suggesting that a trauma is all a trauma survivor's fault or something like that. But in addition to that, I think one of the most important things that you can do is really trying to let the person with PTSD feel their feelings. That is so important in trauma recovery, and trying to be there to support them in that, not forcing them to have an emotion, but not really trying to distract them either and say, oh, don't get upset. Actually, feeling feelings is a really important part of trauma recovery. I think where it becomes trickier when you have BPD involved as well is that we know if emotions get too intense for some people, it can lead them to do things that can be harmful to themselves or other people. So there's kind of an optimal zone that you probably want somebody to be in. But my main piece of feedback is my main thought for people to think about is, how can you help somebody with PTSD feel their feelings, seek treatment, and really, and suggest that it's okay. Like, it's okay to be sad about a trauma. Like, it is okay to have to feel angry about a trauma, to feel fear sometimes, and like giving space for that is really important in recovery.
Great, thank you. I'm going to throw it over to Kathleen and see if she has some questions that have come up for you.
Thanks, Doreen. The first question that I have is, what is the difference between CPTSD and PTSD?
Thank you. That's a great question. So CPTSD stands for complex PTSD. It's a term that's used more and more nowadays. CPTSD is not a formal diagnosis in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, which is what we use in North America for diagnosis. It is in the ICD, which is used in the UK and other places. So CPTSD is a disorder that in the ICD, in this other diagnostic manual, involves PTSD symptoms in addition to some dysregulation of other processes, disrupted emotions, difficulties regulating emotions, problems with relationships, some identity disturbances, and somatic problems, so like body, physical aches and ailments and somatic issues, body issues like that. There's controversy over that diagnosis and whether it's different from BPD, whether BPD plus PTSD is the same thing as CPTSD. That is a debate that kind of rages on in the research literature. And I think that is part of why you don't see that diagnosis formally recognized in the DSM, but it's still kind of given out to people informally quite a bit. And that is what that is referencing, the idea of having PTSD and then some issues with emotions, relationships, and a lot of the things that we see in BPD.
Okay, thank you. The next question is a little bit detailed. We've been trying to get help for our daughter who does not want to get help, and 2, for us in learning how to understand our daughter and not make her worse. Our daughter's 20 and we're looking at BPD assistance basically. They want to know how can they learn what to say or not to say. Sounds like a big struggle.
Yeah. That sounds like a very big struggle. I could only imagine how difficult that is. And I'm sure that there are many people on this webinar and elsewhere in the world who are going through something really similar. So thank you for that question. Of course, it goes without saying that everything I have to say here is really not a personalized recommendation to anybody, not knowing anybody specifically, but more generic thoughts based on the literature. And I'm sure some of the other people in the webinar could jump in about this too, but one of the first places that I would start, or I would suggest that people start in trying to find those resources is Family Connections and some of the work that Family Connections offers for loved ones and trying to help them support their loved one. There's also, I believe, some books. I'm going to have to look up the titles of them, but some books that are for loved ones of people with BPD that might be helpful, and I can try and look those up and pass those along.
Great, thank you, Skye. I'm going to throw just a couple of quick questions at you here before we run out of time, because there's a few themes again. People are asking about PTSD again in general, in terms of its sort of natural lifespan. Does it ever go away on its own? Does it become worse if it's not treated?
Yeah, so like I said, the PTSD symptoms that follow trauma do tend to, in a lot of people, resolve. But once you've gotten to a point where they haven't, you know, if they've been around for, you know, like a few months, you know, often that's when, PTSD can become chronic. And so the good news is that PTSD is very treatable. The bad news is that often if it does not, once you have PTSD, you've not had that recovery that I've talked about. If you do not receive treatment, it's not always likely to go away on its own, that typically this is thought of as a chronic problem until it gets treatment. But the treatments for PTSD outside of the context for BPD vary in length between like 8 and 15 sessions. They can be pretty quick. And like I said, their efficacy is actually quite good.
Thank you. And another one is about the additional complication of addictions or substance use, tying in with whether essentially probably as a numbing or coping strategy.
Yes,
right.
You got it.
How does that play into the treatment options and the readiness?
Thank you for that question. So glad that question was asked. So substance use disorders are very common in PTSD, and we also know that they're very common in BPD as well. So you'll often see people who would be able to be diagnosed with PTSD, BPD, and substance use disorders. It's kind of, in my view, sort of like this triangle that can happen. The really good news is there's been an astounding amount of research that's been done on how to treat people who have PTSD and substance use disorders. Doreen, you're right that often we think of substance use as a strategy that people develop to manage and avoid some trauma reminders and symptoms. There's a great treatment out there called COPE, which is combining prolonged exposure, which I talked about earlier, with substance use treatment. And there's several others as well. There's also lots of research that's been done administering just sort of straight PTSD treatments like prolonged exposure, cognitive processing therapy in people who have both PTSD and substance use disorders. And more research is coming out to suggest that treating PTSD in people who have both of those problems tends to have or can have this downstream effect on substance use. When PTSD gets better, substance use often gets better. And so the literature is increasingly showing that for people who have both those problems, treating PTSD is really important, because treating substance use alone and not treating the PTSD does not have that effect in the research on PTSD.
Great. Kathleen, do you have one more question that could be a quick and general question? I have one if you don't.
Let's go. How do you help a person who has numbed their emotions, are not able to connect at all, and are stuck?
Mm-hmm. Yeah, I mean, I think some of the thoughts that I said earlier in general in terms of how to support people, loved ones with PTSD, often involve trying to help them feel their feelings. And if those people feel numb, you know, without knowing too much about any specific case or being able to speak to any one specific individual, I think that some of the best things we can do is try and highlight for loved ones the role of avoidance, try and highlight the importance of feeling feelings and trying to make ourselves, you know, willing and available to be there if somebody needs to do that processing with us. And otherwise really encouraging them to seek treatment and highlighting that, you know, like, it's not just that distress goes down when people get PTSD treatment, that it's actually like life satisfaction. All of this like positive outcomes can come from those treatments too. There's a phenomenon called post-traumatic growth, which means that a lot of people, once they go through these treatments or after trauma, can feel like they've actually, you know, got this new meaning that's actually really powerful, fulfilling, that their life has been, you know, they've been made stronger in some way. And that's an effect that can happen from these treatments as well. So one of the things that I would be thinking about is just like trying to encourage somebody to get into those treatments, because they're made for that. They're made to help people who have numbing symptoms overcome those things. And the other thing I would just say really quickly is that there are an increasing number of self-help treatments being developed. You know, I'm involved in one of such project right now. And I think, so for those of you who are feeling hopeless, like we are on wait lists, we don't know how to get treatment. There are an increasing number of people who are trying to work on online interventions to get people therapy into their own homes now so that nobody has to be on a wait list. A lot of people are working on those things. And I think that I believe that there are already some prolonged exposure websites and stuff that are focused on that, but that work is being done, and I'm hoping is imminent.
Thank you.